Welcome to the Screening for Diabetes in Adults chapter of the 2018 Diabetes Canada Clinical Practice Guidelines. My name is Dr. Robin Holden. I am Professor and Chair of the Division of Endocrinology at Queen's University and had the pleasure as acting as Chair of the 2018 Guidelines. I would like to start off by thanking lead author Jean-Marie Echo and co-authors Ronald Goldenberg and Pamela Katz for their hard work on this chapter. The chapter continues to reinforce the importance of screening for diabetes using a fasting plasma glucose and/or A1C every 3 years in individuals 40 years of age or older or at high risk using a risk calculator. The chapter contains new information on a de-emphasized role for screening for diabetes with the 75-gram oral glucose tolerance test. In addition, the Arab population has been added as a high-risk population for type 2 diabetes. This slide shows a screening checklist for diabetes. It's important to assess all adults clinically every year for risk of type 2 diabetes. Adults 40 years of age or older or at high risk on a risk calculator should be screened every 3 years. Individuals at very high risk on a risk calculator or with additional risk factors should be screened earlier and more frequently. The fasting plasma glucose and/or A1C should be used as initial screening tests. A substantial number of Canadians are living with undiagnosed type 2 diabetes. The estimated prevalence in the general population is 1.13% by fasting plasma glucose levels and 3.09% by A1C criterion. Based on retinopathy data, it is estimated that the onset of type 2 diabetes occurs 4 to 7 years before its clinical diagnosis. Tests for hyperglycemia can identify individuals who may have or be at risk for preventable diabetes complications. Screening adults as early as age 40 in primary care offices has been shown to be useful in detecting unrecognized diabetes. This slide shows the results of the DIASCAN study. The study used a stratified randomized selection of family physicians across Canada. Consecutive patients 40 years of age or older were screened for diabetes. If a casual capillary blood glucose measurement was greater than 5.5 millimoles per liter, the patient returned for a fasting venous blood glucose test. If the fasting blood glucose was 6.1 to 6.9 millimoles per liter, a 2-hour, 75-gram post-glucose load venous blood glucose was obtained. Results of these tests were used to classify patients into diagnostic categories. Data were available for 9,042 patients. Previously undiagnosed diabetes was discovered in 2.2% of the patients, and new glucose intolerance was found in an additional 3.5% of patients. In the Addition Cambridge study, 33 family medicine practices in eastern England were randomly assigned to screening, followed by intensive, multifaceted treatment for people diagnosed with diabetes, screening plus routine care, and a no-screening control group. The study population consisted of over 20,000 individuals aged 40 to 69 years at high risk of undiagnosed diabetes. Screening for diabetes was not associated with a reduction in all-cause cardiovascular or diabetes-related mortality within 10 years compared to the no-screening control group. However, the low rate of type 2 diabetes in the screened population of 3% was likely too small to affect overall population mortality. The prevalence of diabetes in Canada is higher, raising questions as to whether the results of Addition Cambridge can be applied to Canada. The prevalence of diabetes varies across Canada. In 2008-2009, after accounting for differences in age distribution among the provinces and territories, Newfoundland and Labrador, Nova Scotia, and Ontario had the highest prevalence of diagnosed diabetes, while Nunavut, Alberta, and Quebec ranked lowest. Risk factors for type 2 diabetes include age 40 years or older, first-degree relative with type 2 diabetes, member of high-risk population, and this includes African, Arab, Asian, Hispanic, Indigenous, or South Asian descent, low socioeconomic status, history of prediabetes, this includes impaired glucose tolerance, impaired fasting glucose, or an A1C between 6 to 6.4%, history of gestational diabetes, history of delivery of a macrosomic infant, presence of end organ damage associated with diabetes, including microvascular, retinopathy, neuropathy, nephropathy, and cardiovascular, coronary, cerebrovascular, or peripheral vascular disease. Other risk factors for type 2 diabetes include the presence of vascular risk factors. These include an HDL cholesterol less than 1 millimole per liter in males, less than 1.3 millimoles per liter in females, triglycerides greater than or equal to 1.7 millimoles per liter, hypertension, overweight, abdominal obesity, and smoking. Other risk factors for type 2 diabetes include the presence of associated diseases, such as history of pancreatitis, polycystic ovary syndrome, acanthosis nigricans, hyperuricemia, gout, non-alcoholic steatohepatitis, psychiatric disorders such as bipolar disorder, depression, schizophrenia, HIV infection, obstructive sleep apnea, and cystic fibrosis. Other risk factors for type 2 diabetes include the use of drugs associated with diabetes, including glucocorticoids, atypical antipsychotics, statins, highly active antiretroviral therapy, anti-rejection drugs, and some other drugs listed in an appendix, and other secondary causes of diabetes also listed in an appendix to the guidelines. A number of risk scores based on clinical characteristics have been developed to identify individuals at high risk of having undiagnosed diabetes. However, the impact of known risk factors on having undiagnosed type 2 diabetes differs between populations of different ethnic origins, and risk scores developed in Caucasian populations cannot be applied to populations of other ethnic groups. Furthermore, the prevalence of individuals at risk for developing type 2 diabetes varies considerably according to the scoring system and diagnostic criteria used. As a result, risk scoring systems must be validated for each considered population in order to adequately detect individuals at risk and eventually implement effective prevention strategies. The Canadian Diabetes Risk Assessment Questionnaire, FINRISK, is a statistically valid tool that may be suitable for diabetes risk assessment in Canada's multi-ethnic population and is available on the Internet. CanRisk has not been validated in individuals under the age of 40 and should be used with caution in this age group. This slide shows the CanRisk questionnaire and the questions and scoring system used to identify whether individuals are at low, moderate, or high risk for diabetes. The FINRISK calculator is similar to CanRisk, but does not include macrosomia, ethnicity, or level of education. The risk categories also differ and include low to moderate, high, and very high risk categories. The screening algorithm has been simplified from the 2013 guidelines to reflect a de-emphasized role for the 75-gram oral glucose tolerance test. The algorithm reinforces the importance of screening using a fasting plasma glucose and/or A1C every 3 years in individuals 40 years of age or older, or at high risk using a risk calculator, as well as the importance of earlier and more frequent screening in people with additional risk factors for diabetes or those at very high risk using a risk calculator. If the screen reveals a fasting plasma glucose less than 5.6 and/or an A1C less than 5.5%, the testing is considered to be normal and the individual should be rescreened as recommended. If the screen reveals a fasting plasma glucose greater than or equal to 7 and/or an A1C greater than or equal to 6.5%, the individual can be diagnosed as having diabetes. If the fasting plasma glucose is between 5.6 to 6 and/or the A1C is between 5.5 to 5.9%, the individual is considered to be at risk for diabetes and should be rescreened more often. If the fasting plasma glucose is between 6.1 to 6.9 and/or the A1C is between 6 to 6.4%, the individual can be diagnosed as having prediabetes and should be rescreened more often. Type 1 diabetes is primarily a result of pancreatic beta cell destruction due to an immune-mediated process that is likely incited by environmental factors in genetically predisposed individuals. Ongoing clinical studies are testing different strategies for preventing or reversing early type 1 diabetes in the presence of positive autoimmunity. Given that various serological markers are not universally available, and in the absence of evidence for interventions to prevent or delay type 1 diabetes, no widespread recommendations for screening for type 1 diabetes can be made. And now let's look at the individual recommendations contained in the chapter. Recommendation 1, all individuals should be evaluated annually for type 2 diabetes risk on the basis of demographic and clinical criteria. Recommendation 2, screening for diabetes using fasting plasma glucose and/or A1C should be performed every 3 years in individuals greater than or equal to 40 years of age or at high risk using a risk calculator. Earlier testing and/or more frequent follow-up every 6 to 12 months with either fasting plasma glucose and/or A1C should be considered in those at very high risk using a risk calculator or in people with additional risk factors for diabetes. The chapter also contains a number of key messages for healthcare providers, which I'll show over the next few slides. And it also contains key messages for people with diabetes written in lay language. I encourage you to review the full text of the chapter available at the Diabetes Canada website. The same information can also be obtained by downloading the app.